It's hemolytic, acute, and then there is a pallor there. Ah, lovely. So now, does malaria come with jaundice on day one? No, it's extrahepatic infection with intrahepatic complication. So should come a little later. So this is not malaria. Both came together. Hemolysis, yes. So we have said this jaundice is hemolytic, not hepatic. Okay. Acute onset.
Leptospira is again too early.
Yeah, all
day
that jaundice
day 2 you won't get jaundice.
Wow.
Wow.
Okay. Yeah.
So whether malaria would have crossed the hemolysis and the jaundice?
Yeah, so malaria, what would have happened is fever for a day or two or three and then a complication. The hepatic disease in malaria is a complicated hepatopathy.
No, whether the jaundice would have been due to hemolysis of malaria.
Correct. So the point is, see, when a child gets malaria, he first gets malaria, then he gets hemolysis, then that hemolysis leads to jaundice. So on a time frame, the jaundice has to come a little later if it is due to too much of hemolysis. If it is due to secondary hepatitis also, that hepatitis will take some time.
No,
So
but
these are subtle differences, but the time frame of jaundice in malaria is not day 1, day 2. It will be little later.
And malarial jaundice is never hemolytic jaundice. Okay, the reason is that for jaundice to be clinically seen, you must have at least 3-4 milligrams of bilirubin, not 1 and 2. In a neonate, even 5. Therefore, to produce so much of bilirubin, you must have so many RBCs destroyed. So acute anemia, a child comes with probably a cardiac failure due to acute anemia. When you are 12 grams and you suddenly become 8, you are in trouble. So malaria with jaundice is almost always still proved otherwise a hepatitis and not a hemolytic jaundice, right? Yeah. The problem of malaria with hemolytic jaundice is the G6PD deficient fellow who gets an antimalarial. That's a different story, yeah.
Okay, now 8-year-old presents with fever off and on and abdominal distension for 2 months. So analyze so far. Fever off and on, so is it an infection? Maybe chronic infection. Now take abdominal distension. What do you want to know about abdominal distension? It's been there for 2 months. So what is it likely to be? Abdominal distension over days or weeks, what did we say it was? Ascites or organomegaly. Okay, ascites is usually in a shorter period. So this is longer, so it's
and
like
again with ascites and hepatosplenomegaly, we made a point that ascites, suppose he comes with ascites for 2 months. Okay, the story would be first 1 or 2 weeks I had a gradually distending abdomen and thereafter it has remained static. Whereas if it's a hepatosplenomegaly, it has always been increasing over 2 months. Why is that? Because when the peritoneal fluid accumulates, there is an equilibrium between secretion and absorption. So usually a nature will keep a balance and nothing will go on adding. But in a hepatosplenomegaly, it can go on. So small subtle thing. Parents may not even know whether first 2 weeks it increased and next 2 weeks did not increase. But we must attempt to ask all these questions, right? So you might be able to differentiate even an ascites form hepatosplenomegaly on progress of abdominal distension. Yeah.
okay, so now let's look at what we have. Healthy child looks unwell, JVP is raised, hepatojugular reflux is negative, liver is firm, not tender, no splenomegaly, no ascites. So now what do we interpret out of
So
this?
we could go different ways. We have already said subacute or chronic infection. Forget that. Just go by the liver. We saw the chart. Liver only. No spleen, no ascites. What is it?
Post-sinusoidal, you normally want ascites. There is no ascites here. Okay. So, liver, now what is this JVP which is raised? JVP which is raised suggests
venous congestion,
venous congestion.
but chariot goes.
Okay. So that's what. We are now further splitting here. Suppose this was Budd-Chiari, then we wanted an ascites also. So this is not Budd-Chiari. But JVP is raised. So there is either venous congestion or venous obstruction.
So here we will say superior venous vena cava obstruction.
Okay.
Not inferior vena cava. If it was inferior vena cava, there would have been ascites. Superior vena cava obstruction. Why obstruction? Reflex is not there.
Hepatojugular reflux is negative.
Okay, negative reflux, distended vein, obstruction. Obstruction where? Superior vena cava. Superior vena cava obstruction, and then now gradually spreading to inferior vena cava because the liver is enlarging. Okay, so now superior vena cava and inferior vena cava obstruction. So what's the common site? Pericardium. Okay, chronic infection in the pericardium. What's the diagnosis? Constrictive pericarditis tubercular. Okay. So I think gradually if we go on that, only liver would have mistaken us somewhere. But this helped us to do that, right?
Okay.
And that's why we said earlier in a liver discussion, every large liver, look at the neck veins. It may not be a liver disease, it may be a venous disease.
Again, 8-year-old child presents with mild fever and abdominal distension for last 2 months. So in the previous child, what had we said? Fever and abdominal distension. We said chronic infection. So far we are at that. Now let's see what is there on examination. On examination, healthy child, ascites is there, no hepatosplenomegaly. So ascites means, we said anatomy, ascites only. Anatomy is peritoneum. Background of mild fever for 2 months. So what kind of infection? Use an adjective. Subacute infection of the peritoneum. So anatomy peritoneum, pathology subacute infection. So diagnosis is tuberculosis. Okay. Okay. Now abdominal distension for 2 years. Distension increased over the first few months and thereafter has been static. What is your comment so far? So 2 years of abdominal distension. Initially the distension increased and then became static. Just now sir said that happens in ascites. So this is ascites for 2 years.
But no other symptoms.
So think
this
now.
is not ascites, but ascites like abdominal condition. What is ascites like abdominal condition? Yeah. So it is a mesenteric or an ovarian cyst. Was fluid clear, ascites common, but not for 2 years in a otherwise normal child. So benign, long-standing fluid in the abdomen. So localized. Ascites, no, it is a fluid, all right. So let's call it as a fluid in the peritoneal cavity. But this is a localized, looks like, right?
So on examination, healthy, happy child, but ascites is there and ascitic tap is inconclusive and there is nothing else. So you already said that this looks like ascites, but it is not actually ascites. So ascites cannot remain static without symptoms or deterioration. So this is misdiagnosed as ascites and therefore this was a large mesenteric
Actually,
cyst.
I want to tell you how my intern who had just passed MBBS diagnosed this correctly. Okay, he told me on the round, sir, there is an ascites, but we have learnt in undergraduate days, sign of ascites is a smiling umbilicus. Okay, some of those things we remember better than anything else. But he said, sir, this is half smiling umbilicus. Oh, I think it was such a wonderful observation. He said, sir, half smiling. He did not know half smiling was a mesenteric cyst on that side, not on the other side, extending on the other side. Half smiling umbilicus. Okay, even the textbooks have not written that, intern knew. A good observation, isn't it? I learned from him half smiling umbilicus. So, isn't it? Yeah, mostly we don't smile at all. If we smile per force, full smile. But half smile, yes, assist. Yeah. Okay, so that's good.
Okay. Now fever off and on, abdominal distension for 2 months. So same analysis that this could be some chronic process, subacute. On examination, undernourished child, liver plus firm, spleen plus no ascites. So based on liver, spleen and ascites, where is the anatomy? Within the liver, is it hepatocyte? Is it venous? Is it biliary or is it reticuloendothelial? Reticuloendothelial.
So chronic infection.
And fever off and on for 2 months.
But undernourished child.
So slowly progressive hepatosplenomegaly without hepatocyte dysfunction suggests RE cell disease. This is subacute infection, so this is disseminated tuberculosis. Okay. Now 8-year-old presents with abdominal distension for 6 months, which is gradually increasing, fever off and on, general ill health, anorexia, occasional loose stools and vomiting. So far, what do you think? Take everything. Abdominal distension, so we said what could it be? Abdominal distension, organomegaly or ascites. Now fever off and on. So we are expecting organomegaly and we are expecting either a chronic infection or some reticuloendothelial process. Now there is general ill health. There are other systems involved as if the GI tract is also involved. This is the analysis so far. Now on examination, wasted and stunted child, liver firm, spleen firm, no ascites.
So I think at the first stage, let's call it as a multi-system disease. So far, none of the liver diseases or ascites or whatever we discussed had loose stool vomiting. So looks like a multi-system disease in an undernourished child who is now wasted, stunted, so chronic malnutrition. 8-year-old, so secondary malnutrition, liver firm, spleen plus, no ascites. What
And
do you
now
think here?
we said liver, spleen, no ascites means again which category? RE cell. So RE cell, multi-system disease, wasted and stunted child. Yes? Immunodeficiency.
Fine.
And now I'll give you the cat out of the bag. Bilateral parotid swelling. HIV. So severe deteriorating health parameters suggest a fastly progressive disease and therefore this is
But
HIV.
see how the fun, before we said bilateral parotid swelling, you said immunodeficiency. An 8-year-old immunodeficiency is HIV. So even before parotids came in, we could know that, right? Just because we said multi-system, chronically wasted, undernourished 8-year-old. Oh, now if you said fungal infection in the mouth, what? Even the grandmother should know it's HIV. So we did not, yeah.
Okay, so excellent, very good. Now 8-year-old abdominal distension with 4 episodes of hematemesis over last 2 years. What do you think this is?
Pre-sinusoidal, sinusoidal or post-sinusoidal?
Okay. So can it be post-sinusoidal? Okay, fine. What do you want to call it? Pre-sinusoidal, sinusoidal or post-sinusoidal? Yeah. Yeah, so you want liver spleen, right? Very good. So let's see what we have. We have a healthy, comfortable child with liver, spleen, but no ascites. So now tell us, pre-sinusoidal, sinusoidal or post-sinusoidal? So where is the ascites? In
And why
post-sinusoidal we
spleen?
wanted,
You won't get spleen in
And we
post
didn't- we
So not
shouldn't have
post-sinusoidal. Sinusoidal, but he is healthy and comfortable, so not sinusoidal. And if it's pre-sinusoidal, why liver? So it's neither pre-sinusoidal, sinusoidal, but portal hypertension, all right.
RE cell, yes, but then he has hematemesis, 4 episodes.
So venous channel disease.
So there is a portal hypertension, there's no doubt about that.
So I think this is the situation where we say not post-sinusoidal, not sinusoidal because he is healthy, not pre-sinusoidal because the liver, okay. But he is healthy, you know, out of these 3, post-sinusoidal can be ruled out, no ascites. And therefore this must be pre-sinusoidal obstruction. Now pre-sinusoidal with liver, so this is an exceptional pre-sinusoidal. So now what we are going to learn is pre-sinusoidal can be extrahepatic or intrahepatic. And this is pre-sinusoidal intrahepatic. That's why the liver is large. Okay. And I think that is how. We are just trying to further now because at the end of the day we find that you are as bad as we are or as good as we are. Yeah. So now something more. So pre-sinusoidal intrahepatic. What is pre-sinusoidal intrahepatic? Hepatocytes are not yet involved. So not sinusoidal. But pre-sinusoidal inside the liver. This is congenital hepatic fibrosis. Okay. Large liver, but looking like a pre-sinusoidal. So we are making it now a little complicated. Somebody told me in the morning, you started as if it was an undergraduate. Not undergraduate, I thanked him. He almost meant a school only. Okay, but then he said, oh, you took us to IgA nephropathy and Crohn, so we were happy. So this is pre-sinusoidal intrahepatic diagnosis, congenital hepatic fibrosis. Yeah?
Okay.
All right?
Now, 8-year-old presents with recurrent abdominal distension and vomiting for 2 months. Fever off and on for 1 month. Symptoms would get relieved after symptomatic treatment. So, recurrent abdominal distension and vomiting, what would you think of? Recurrent. So, gaseous, okay, would they have vomiting? No. So,
Obstruction.
subacute obstruction.
Recurrent obstruction, right?
Okay.
Subacute, getting
Yeah.
better, coming again. Subacute intestinal obstruction.
With
right?
fever off and on.
So infective, off and on for 2 months. Subacute infective, recurrent intestinal obstruction. Yeah. So now diagnosis made, right? What
Okay.
diagnosis?
So, subacute recurrent intestinal obstruction, fever suggests inflammation. So, it is either subacute infection or non-infective
even lymphomas.
inflammation.
Okay. So we say infective inflammation or non-infective inflammation. So
So-
ultrasound, lymph nodes there on Hodgkin's. Okay.
Okay. So, I think that's it. So,
We just end up with some take-home messages. Yeah.
so just some take-home message. Yes. Yeah.
How to diagnose this extrahepatic congenital hepatic fibrosis, sir? Please enlighten more on that because it carries a good prognosis among all the portal hypertension.
Sir, clinically, as we said, congenital hepatic fibrosis is a condition where there is fibrosis in the liver, but the hepatocytes are not involved yet. So there is no hepatocyte dysfunction. So there is no true liver disease in that sense. So this child is healthy. But because there is fibrosis, this fibrosis causes portal hypertension. So because of the portal hypertension, this child will have a spleen and this child will bleed repeatedly. So he almost looks like extrahepatic portal hypertension, but because there is fibrosis going on in the liver gets enlarged. So a child who looks like extrahepatic portal hypertension with spleen and bleeding, but also has a liver, but no liver dysfunction, no disease, that is a child with congenital hepatic fibrosis.
I think occasionally when this child has a large bout of hematemesis and he loses lot of blood, he might come with a transient jaundice and a hepatic failure.
So
Because
that
one of the
the-
causes of hepatic failure is aggravation is
The
the loss of blood.
the hematemesis is due to what, sir? Portal hypertension.
Portal hypertension.
Portal
Yeah.
hypertension.
What is the prognosis when compared to other this one? This condition.
Prognosis will,
Prognosis is usually good. Okay, but
After splenectomy, does it carry good prognosis? This child?
no, splenectomy is not the treatment for this.
he would need a shunting procedures, and today we have what is known as a TIPS. So many catheter related shunting procedures are available. They certainly need treatment because he's throwing up a repeated hematemesis.
Otherwise, sir, what are the straightaway straightaway diagnostic points for this condition? Straightaway diagnostic points: hepatomegaly, splenomegaly, portal hypertension.
Yeah, without hepatocyte dysfunction. So your albumin and your everything will be normal. Your hepatocyte
Thank you.
parameters will be normal. Okay? Yeah. So the first message is that systematic thinking leads the way for obtaining a relevant history and performing focused physical examination. Second is that structured analysis of symptom complex helps to define the probable or provisional diagnosis in most cases. Physical examination adds to fine-tune this diagnosis, and then relevant laboratory tests are planned only to confirm the diagnosis. This way there is a marked reduction in the number of tests we ask for. This alone would pave the way for rational therapy. The commonest argument against this is lack of confidence. What if I am wrong? Confidence is built up only when we practice implementation of this approach. This will reduce over dependency on lab tests. And with repeated practice, it won't take time. Spending time for excellence and rationality is worth it anyway. Thank you so much. See, we all practice for different reasons. Maybe most of us, 99% of us may be practicing for money. But if you want joy in what you are doing, whatever you are doing, you have to be excellent in your job. And if you are excellent in your job, that joy is inherent. So that is what is excellence all about. Thank you.
Hope everybody would have enjoyed this the whole day, and particularly like a World Cup World Cup yesterday, World Cup finals. This was a wonderful session today we had. Particularly the afternoon session was like a slog overs, and hope everybody would have enjoyed. Now we come up to the main aspect of the thing, presentation ceremony. I ask senior most pediatrician of the Cuddalore district, Dr. Murugesan sir, to hand over the memento to our master teacher, Professor YK. Now I call upon Dr. V. Chandrasekharan, our neighbor district senior most pediatrician, to come and hand over the presentation to Dr. Rajesh Chokani, who has proved that he is better than everything. Now let us have a standing ovation for both of the speakers we had. Anthem.
Jaya Jaya